everyone. Good morning. I'm excited to have a great lineup of resident speakers today. The last hour of the day will be split between intern report and senior report, so just go to the appropriate lecture. But we'll start this morning with Cody Gehring. He's going to talk to us about deprescribing, and we are so happy to have him. Cody, take it away.
Hey everybody, good morning. If we haven't met before, I'm Cody Gehring. I'm an R2 in the primary care track. My clinic's at the VA. I decided to do this talk. I'm not a geriatrician or a palliative care doctor, but I think this topic pertains to all of us in internal medicine, and really I think throughout medicine. So I'm excited to kind of do it just like an intro primer to thinking about a little bit more about multimorbidity and deprescribing. My disclosures, I have no financial disclosures. These aren't based on real cases. I just made them up, and I am guilty of corny jokes, so apologies in advance. Our objectives today, so I'd like to define multimorbidity and comorbidity, learn to utilize a basic framework for multimorbidity, develop a basic approach to deprescribing. This is not an advanced primer on deprescribing by any means, but just to kind of get us thinking about it a little bit more. We'll do a brief dive into some evidence, and we're not going to talk about cancer screening today just because that is a kind of big topic in and of itself. So what is multimorbidity? So I think sometimes we confuse multimorbidity with comorbidity. So comorbidity actually is like a disease that occurs in the context of an index disease. This picture uses the example of cancer, but I think maybe a better example would be something like neuropathy in the context of diabetes. Or kidney disease in the context of diabetes, whereas multimorbidity would be something like heart failure, diabetes, and maybe cancer. So it's just, I think, helpful to kind of parse that out a little bit. And that usually manifests itself in a problem list. Why do we care? Well, it's really, really common. So more than 50% of older adults have 3 or more chronic diseases. This increases over time. And then I think the other piece is that underserved populations tend to have higher burdens of multimorbidity as well. And it affects every aspect of our practice. I like this framework just for thinking a little bit more about kind of the natural progression of disease and how we sort of get to this point. So you can look here on the left, sort of the like underlying biologic factors for aging. And then those, affect organ systems. And then eventually that translates into multimorbid diseases. And what we really care about is on the far left, thinking about quality of life, disability, and how it affects our day-to-day practice and our patients' lives. And one of the big challenges is, it's complex. I think as internists, we sort of pride ourselves on working with complexity, but it makes our job very hard. When we look at most randomized controlled trials and the evidence for disease-specific treatments, they usually only focus on a single endpoint or maybe a composite endpoint in the context of an individual disease with an individual treatment. And they almost always exclude multimorbid patients or older patients. So next time you're looking at a big study, like say the SPRINT trial, for example, where they had, a very pretty large cohort, you'll see that they excluded a lot of people in that study, including something like diabetes. So how do we work with this? I mean, I think, a lot of this is through experience over time. We get this in our training to some degree, but I think it's helpful to be a little bit more intentional and systematic about how we work with multimorbidity. The American Geriatric Society has a nice set of guidelines with sort of like a flow diagram on how to approach it. I did think it was maybe a little bit long, and so I tried to distill it down to what I thought the kind of main points that were a little easier for me to digest. I didn't come up with a super great mnemonic. I guess you could use pepper. I don't know. But I think just like thinking about these general buckets is helpful. So I'll go through these here in a second. So I think number one is, who's the patient in front of you? What are their preferences and values? I think it's good to know who their people are in their lives: family, loved ones, friends, support. Those are going to be the people who help navigate you through illness. It's good to know how they like to make decisions. Sometimes we encounter the engineer who comes in with spreadsheets and wants to know more exact numbers. Sometimes it's people that just want to know big picture. I think, most people kind of fall in between. And then really getting at goals of care. What do people value? I think one good way, and I'm really thinking about how to approach this in clinic because I think your time is often limited. So a good question to ask somebody is, what does a good day look like to you? Or what does a bad day look like? And you can often gather this through conversation over time, and that's the value of a longitudinal relationship. And then there's sort of like different domains that you can categorize people's values and goals within. Some people tend to focus on longevity. I think it's tricky because I think, if you ask any person, like most people will say, yeah, I mean, if I have the option, I'd like to live longer. So I think it's good to like pinpoint what that means and what that looks like. And also sometimes people have just like a specific goal in mind. I had one patient who said, I just want to make it to my granddaughter's like third birthday in 5 months. So I think that can be helpful. Talking about somebody's function, some people tend to focus more on comfort, and for some people it's independence. My grandma, she like, that was the only thing that she cared about at the end of her life, and I think her doctor did a really nice job of supporting that goal. And I think thinking about culture as well. So, in Western society, we often focus on what the patient individually wants, but I think we have to remember that there are family units and different ways people approach that as well. Oh, sorry. Okay, this should say number 2 actually. So evidence for treatment. So I think this is where it can get challenging, is again, looking at studies and seeing how it applies to your patient. Looking at the demographic information in the study is super important. So age, gender, socioeconomic status, things that you can't necessarily gather are cultural differences. And oftentimes studies don't represent marginalized populations. I think it's helpful to think about how much a treatment's going to impact them. One useful number is the number needed to treat and the number needed to harm. And then thinking about how long it will take to work, and then how long will it work is the other thing. So a concept of lag time to benefit is important. So you ideally have somebody's life expectancy longer than their time to benefit. And one useful tool is looking at Kaplan-Meier curves for this. And then thinking about somebody's baseline risk factors as well. So if their baseline risk is 0.5% and you have a relative risk reduction of 25%, it may not necessarily be that meaningful. Next slide, okay. So I think also just kind of thinking about like, this has historically been a big theme in medicine, is like, I think as doctors, we often think that we're the big factor in moving the needle in someone's course of illness, but in reality, we're a pretty small part of it in most cases. And I think this historically goes back. If I don't know if any of you read Tolstoy, but I kind of like this quote: allowing the patient to heal despite what we're doing. The Curbsiders podcast has a really nice episode on multimorbidity. I recommend you give it a listen. I'm not going to go through this, but they actually made a table on some like common disease-specific treatments and the number needed to treat. So I do recommend. I'll leave this in the slides for you. And then like the next thing is thinking about prognosis and multimorbidity. Prognosis can often be hard to estimate. There are tools online to use to like quantify it better. ePrognosis is one that I think is kind of helpful. And it kind of talks about like disease specific or prognosis is specific to a lag time to benefit. Thinking about somebody's functional status and their mental health and well-being. There are some scoring systems for this as well. So frailty score, ECOG, palliative performance score. And then thinking about, how any given treatment will affect other conditions in a multimorbid patient. I think, when you're facing this complexity, I think it's good to remind yourself to like go back to the goals of care, go back to those values. That will help you keep in check. And the other thing is, geriatrics does a really nice job of like lumping things into syndrome, thinking more about syndromes and systems rather than disease specific problems. So delirium, falls, polypharmacy, etc. Here's the ePrognosis website. You can just plug in some data. It's pretty helpful. It's developed by some palliative care doctors. And then think about the practical considerations of any given treatment. So anytime we add another pill, we're setting ourselves up for more challenges, particularly if we're asking somebody to take multiple pills multiple times a day. And it may be really difficult for our patients to implement these treatments. There's cost factors, access to medications, insurance, and if somebody's dealing with housing or food insecurity, like they're not going to be worried about taking a statin, right? So I think it's always important to really focus on that bigger picture. And then reassess. So multimorbidity and prognosis and values can change over time. I think it's easy to just sort of like keep adding on meds for each problem at a new visit. But every time like I said, every time you add a new med, it can potentially create more problems. And so anytime you're sort of find yourself escalating treatments, I think it's good to take a pause and ask, like, is this a marker of a change in their prognosis? And what does the patient want? So let's go ahead and just do a case. Feel free to, I'm having trouble accessing the chat, but maybe Lauren can help me out there. And then feel free to pitch in by microphone as well. We can chat about it. So you're saying Mrs. W, she's 99. You actually, this is like maybe your second visit with her. She transferred care to you recently because she knew you had just attended this lecture on multimorbidity, and now you're a total pro. Here for routine follow-up. So she's accompanied by her daughter, who brings a list of concerns. She has a history of depression, GERD, Alzheimer's, hypertension, diabetes. Her last A1C was 6.4%. Her daughter tells you that she's lost about 20 pounds in the past year. She's living alone in an apartment right now. Daughter does check in on her sometimes. She's walking a little bit less. She's complaining of some hip pain. She walks with a cane. She's had 2 falls in the past 3 months. Last month, she was actually hospitalized for a fall. It was unclear if she had a syncopal episode. Her workup was negative. She didn't sustain any fractures. For her daughter, she seems a little bit more confused. She's often up all night and then sleeping during the day. She needs help with some basic household tasks and bills. She does have a Mediset, but there's often doses of medications that are missed. Her blood pressure is 105/60. Her heart rate's 82. She appears thin. She's slow to rise from a chair, and she has an antalgic gait. She is oriented to herself, location, but not the date. She has a flat affect. Her MoCA is 23. When you ask Miss W, what she would like to focus on or what's bothering her today, she says, my hip hurts. That's kind of all she really tells you. Daughter tells you she's worried, and then kind of wants to go into detail a little bit more about each problem. So we go to her med list and go through it. So she takes an aspirin. She takes Tylenol. She's been taking Benadryl as needed for sleep. She takes cetirizine. Unclear how often she's taking that. She takes citalopram. She takes dextromethorphan guaifenesin for cough. Again, unclear if she's actually taking it. She's prescribed glipizide IR 5 milligrams twice daily. Takes losartan, Maalox, melatonin, metformin, omeprazole, ranitidine, and simvastatin. So I want to pause for questions and just like your initial thoughts. There's, I think, a lot to unpack here. And, honestly, this isn't that abnormal of a visit. I got the chat pulled up here. So Priyanka says, I'm worried about her falls. Yeah. She needs not to live alone anymore. Great. Definitely scale back on a lot of the meds, Brian. Yeah. Many of those medications modify long-term risks that are not relevant for her at this point. Yeah. So what do you all think about her prognosis? I know kind of limited info, but yeah, I put some low-hanging fruits in there in terms of maybe some obvious like troublemaker meds in there. Seep says she sounds delirious. Yeah, waxing and waning, attention. Any other thoughts? Honestly, is Cameron says, honestly, at 99, just take me off my statin. Yeah. Lots of beers criteria. Okay, great. Yeah. Yeah, so I mean, I think her prognosis is probably not great, right? She has some dementia. She's having a decline in her functional status. She's lost some weight. She's struggling with delirium. Her home needs are increasing. So I made kind of a list of some kind of topics that we could address in this visit. Does anybody, so like this is a lot, right? Like, and let's say you have a 45-minute visit, just to be sort of generous. Like, how would you approach this in a visit? Obviously, you're going to have multiple visits, but like, what would you start with? Seep says reducing falls. Immediately schedule the follow-up visit. Housing. Yeah, great. Housing and meds. Meds. How does she feel about independence? Hasib, yeah, exactly. So Hasib says, she may not be able to get her housing this visit. So I think that's one thing to, like, it'd be great if I could just magically like set her up with supportive housing. But we all know the reality. So I think polypharmacy would be the thing I would personally focus on this visit. And I think we could at least lump these 4 things, if not more, into the polypharmacy. So the falls, confusion, delirium, weight loss, and then concerns like she's taking glipizide, so I'm worried, is she having like wildly fluctuating blood glucose? And like a goal A1C for her would probably be much higher, right? 8, 9. Okay, great. So a little bit more about her preferences and values. So she likes to spend time with family and friends. She likes to share decisions with her daughter. A good day for her is crocheting, relaxing at home, spending time with family, she's a little bit more focused on comfort. She doesn't necessarily want to go through a lot of like major medical interventions. I think prognosis and multimorbidity we kind of talked on, but I think the most immediate concern for me is her safety. And then we'll talk a little bit about evidence for different treatments, and the practical considerations. So she has a high pill burden. We're pretty worried about her adherence. We didn't talk about cost, but I think that's another piece that's always important to think about. So how do you go about deprescribing? This can be tricky, but I think just taking you're halfway there if you're taking a pause at each visit to review the med list. Think about the indications and think about deprescribing at least one medication. So, you want to do a good med rec, think about the indications, look at each med and look to see if it's causing harm. And then think about that in the context of the goals of care and evidence that we talked about earlier. Pick the most dangerous meds first, and then kind of go down the list over time. And you want to do it in a stepwise fashion normally, unless you feel like you could discontinue multiple meds at once safely. So a pharmacist shared this with me. These are some meds that she often recommends considering deprescribing. I'm not going to go into detail on all of these, but just to kind of like think about it in terms of ones that are often maybe worthwhile to deprescribe. There's a ton of resources for deprescribing. I think the Beers list is a good one. There's a whole bunch of ones here. I think Andrew maybe mentioned the anticholinergic burden. So acbcalc.com can actually quantify like how much anticholinergic burden somebody has. So here's a nice list. And use pharmacy. They're great help in this regard. They're so valuable. So going back to her list, which meds did we say? So I think somebody mentioned the aspirin. What would be the indication for her aspirin? She didn't have any known coronary disease, so it was maybe a remnant of sort of like older recommendations for aspirin for primary prevention. Probably not going to help. Tylenol, she's probably taking that for her hip. Seems reasonable to continue. Does anybody want to continue the Benadryl? Okay. No, all caps. Great. Yeah. So high anticholinergic burden, causing a lot of problems. Cetirizine. So you ask her, and she's like, "I don't know. Somebody gave me that to me a long time ago. I'm not actually taking it." So I would probably take that off the MAR. It has anticholinergic effects. What about the citalopram? Would any of you consider deprescribing that? Julie says I would keep it. Yeah, I would keep it too. I think relatively safe, few drug-drug interactions. Her mental health is going to be important, and could definitely affect her mental status. She tells you she hasn't been taking the Robitussin. Glipizide, high risk for hypoglycemia. The losartan, what about that? Does anybody have thoughts on the losartan? Her blood pressure was like 100. Izzy says at least reduce the dose, mostly long-term benefits. Yeah. So it turns out in my review, like actually, like short term, like you do have a fairly short lag time to benefit with blood pressure meds, but I think being much more careful, like with your blood pressure control, is going to be important. And so with her, I would probably either reduce it or get rid of it altogether. I probably lean towards getting rid of it altogether. What about so the Malox? She said she sometimes gets stomach upset. She's taking that occasionally, and she tells you. I really should say the daughter tells you that she's missed like quite a few doses of the metformin. What do you all think about the metformin? A1C was like 6 point something. Also probably not necessary. Yeah. So her goal A1C is probably closer to 8 or 9. And Cameron nicely pointed out that it may be actually contributing to her stomach upset. So especially when you're not taking it regularly, it can contribute more GI upset. So I would get rid of it most likely. It seems to be causing more problems. Omeprazole. So looking back, it looks like this was started for GERD like 4 years ago. Any thoughts? She's supposedly taking it BID. Julie says that's a big dose for GERD. Yeah. So probably not helpful to be taking BID dose. So I would agree, at least go down to once daily. And honestly, maybe consider getting rid of it altogether. I'm not going to go delve into the PPI thing just because it's like a long discussion, but it's probably not helping. And then she's also taking ranitidine. If I go back to the list, ranitidine does get 1 point for anticholinergic effects. So I probably would consider stopping that. And then what about the statin? DC, gone. Great. Yeah. No, I agree. So I kind of made some notes here. So I think like earlier on, the sort of meds that I would favor getting rid of soon would be Benadryl, the cetirizine, glipizide, the losartan. And then really all of these in red, I would potentially consider getting rid of or decreasing over time. So your reassessor, and I think this is the really important thing, is you want to see how people do, because you can cause problems deprescribing. So you find out she's actually sleeping a lot better at night now. Her confusion's improved, and you're able to focus on her hip pain and her home situation and her weight loss and all these other topics at a future visit. Great. Do we have time for another case? I want to pause for questions first. Okay, great. We'll briefly delve into this case. We may not have enough time. Yeah, everybody, Cameron says, excited how jazzed everyone is about getting rid of meds. Yeah, it feels good, I think. I think it's nice for patients, and it also takes some stress off. Like causing, you're basically like reducing risk over time. So I don't know if any of you have seen The Munsters, like an old school show. This is Grandpa. He's plays a vampire on the show. He is 378 years old, and he asks you, Doc, do I have to take a statin? Has a history of hypertension, hyperlipidemia, COPD, gout, OA, OSA, BPH, iron deficiency. He's allergic to garlic and the sun. He has to stop to catch his breath after walking up a flight of stairs. He has no chest discomfort or heart failure symptoms, no known cardiovascular disease. He was hospitalized twice in the past year for a COPD exacerbation. He has no urinary symptoms. He lives in a house with his family. He's independent. Memory's been good. He's satting 92% on ambient air. Blood pressure is 125/70. He's accompanied by his pet bat named Igor. He's oriented. He has a normal respiratory effort, diminished breath sounds, no wheezes. And then there's his cholesterol panel. So Julie says his age disqualifies him for a statin. Yeah, we'll get to that. Great. So he takes labalama and ICS, finasteride, tamsulosin, atorvastatin, we'll say 40 milligrams, allopurinol and amlodipine. So the question is statins for primary prevention. So again, I think we can go back to our framework. So we asked him a little bit about his preferences and values. He says, I'm okay with my current inhaler regimen. He wants to reduce the pills that he's taking, but he is okay taking it if there's no major side effects. He prefers to spend time with his family and work on lab experiments. He's okay with some short hospital stays, but nothing prolonged, and he prefers not to go to the doctor. So what's his prognosis? So he actually says, contrary to popular belief, we aren't immortal. The average life expectancy of vampires is around 382 years. He's 378. Hashtag VampFacts. Best guess mortality, maybe like 2 to 5 years for him, based on an average life expectancy and his severe COPD and comorbidities. I actually just plugged his numbers into the ePrognosis. The option is like greater than, I forget how old. It was like the upper end of age, and they gave him a life expectancy of roughly 3.8 to 5.1 years. So evidence for treatment. So the question about statins for primary prevention in elderly and multimorbid patients is really tricky. If you look at the guidelines, they're kind of all over the place. Most of guidelines either don't give recommendations for older adults, or they talk about shared decision making. So it can be kind of tricky. There are some smaller studies. Most of the major randomized controlled trials that looked at statins, like the Jupiter trial, had a small mix of older adults in there, but most of them don't really have high quality enough data. There is one study they did an RCT looking at discontinuing statin therapy in the setting of advanced life-limiting illness, and they monitored folks for up to a year. And there was roughly 13 versus 11 cardiovascular events respectively, but quite a bit of cost saving. So really no major issue. It seemed pretty clear that discontinuing in the setting of advanced life-limiting illness in the time frame of a year was reasonable. There was a large cohort study done at the VA of over 300,000 veterans, average aged 81, and they looked at all-cause mortality and major cardiovascular events at 6.8 years. it is important to note that 97% of the study population were men and 90% were white. And they found a hazard ratio of 0.8, so 66 versus 70 per 1,000 person years. So there is like some difference, but I honestly wasn't super impressed with the numbers. And again, like a little like doesn't necessarily widely apply to, or it's a little harder to generalize. There was another study done in Korea looking at adults older than age 75, a retrospective cohort study. Here's the Kaplan-Meier curve. So there is, again, some difference in cardiovascular events on the left and all-cause mortality. So, you know, I think stay tuned. I have heard that they're I forget the name of the study, but they are doing a randomized control trial in older adults for primary prevention. So we may actually have some more valuable data coming down the pipeline. So some practical considerations. His copay is about $10 a month, which he'd rather spend on buying food for Igor. But he's like, you know, if it really helps, and he usually remembers to take his meds. So again, take home on statins. It's probably most efficacious within 2 to 5 years, is like kind of the take home I got from my review of the studies. But if life expectancy is less than 2 years, it's unlikely to be helpful. And it is an extra pill. There's some, you know, there's side effects and then drug-drug interaction. So, you know, again, it kind of does come down to shared decision making. So you decided to continue this statin with him. He felt okay with it. And you follow up in about 2 years. He has 3 more hospitalizations. His COPD is a bit worse. He's still smoking, but he decides to stop the statin, spend some more time with family at home. So what are our take-home points? Again, this is really just intended to be like an intro to get you thinking more about looking at the data. And I think, you know, utilizing things like Kaplan-Meier curves can be really helpful. And then having a framework for multimorbidity, which we encounter all the time. Review the med list and deprescribe when you can, because I think it's really rewarding, and B, it helps patients. There's lots of good resources online. There's the American Geriatric Society. There's another one called deprescribing.org, which has some nice algorithms for more common drugs. Prognosis, which we talked about, the Anticholinergic burden website, Beer's List. I recommend listening to the Curbsider episode on multimorbidity. And then special thanks to Dr. Ruru Wang, who's one of the geriatricians. She sent me some really great info on this. And then also Carol Crawford, who's a pharmacist at the geriatric clinic. Here's some of my references, and I will pause for questions. I know it's kind of a whirlwind talk. Lauren says, feels easy to deprescribe in the 9-year-old, but how about those 60 to 70-year-olds who have lots of comorbidities and declining function, whose life expectancy is much more confusing? Yeah, exactly. I mean, that's where it's hard. And I think, I feel frustrated that, you know, our studies don't well represent multimorbid patients. And especially when the prognosis is unclear, it can be much trickier. And so that's where I think, as much as you can, familiarize yourself with like the major studies that are used for like treatment indications. And I'm thinking like SPRINT trial, you know, statin trials, et cetera. The more that can help. But oftentimes it really does, I think, go back to the goals of care and values. And kind of going back to that can be really helpful. And then a lot of times it's practical considerations. So medication costs, pill burden, et cetera. But yes, it is very hard. And that's why, I mean, palliative care and geriatrics are specialty fields in and of themselves. And oftentimes when you're in that scenario where it's tough, I think, getting that extra help from like palliative care especially can be super helpful. Catherine asks, what are your thoughts on deprescribing the inpatient setting? Yeah, so I didn't really talk too much about inpatient care, but I think it's important to recognize that oftentimes we escalate medication treatments in hospital when we like for example, blood pressure medicines, like very, very common for a person's outpatient blood pressure regimen to be escalated in the hospital. And there's a very strong signal for increased risk and mortality when we do that. I think the same applies for escalation of diabetes treatments like insulin. So I would take a pause when you're thinking about doing that in the hospital, like increasing somebody's blood pressure, outpatient blood pressure medications, or increasing their insulin. You need to be very careful about that. And then in terms of deprescribing, I think, it's kind of case by case. And I think that generally, though, it is okay, especially if you recognize that a medicine is causing harm. I think if a medicine's causing harm, then very, very reasonable to deprescribe. If it's a medicine that has a little more nuance and you're looking at like, questions about like lag time to benefit over years and prognosis is years, then I think in that case, it may be more worthwhile to defer to the PCP who knows the patient longer. But yeah, I guess that's my initial thoughts. But I think you should feel empowered to deprescribe in the inpatient setting, especially if you think it's causing harm. Yeah, and you can make recommendations in the DC summary as well. I think that's really helpful. 200 milligrams of metoprolol for hypertension, Hasib says. Yeah, seems problematic. I'm curious, have many of you done much deprescribing in clinic?
Maybe when people are typing, just to answer your question, I feel like I have it's like obvious to me sometimes I should deprescribe when people come with like problems, sort of like your case, like a fall or like a hospitalization or something like that. But I don't feel like I'm very systematic about it, just with like reviewing it when things are like going well, even though there is a lot of polypharmacy. I don't know if you have any tips or if there's anything you do in your practice to like help you remember to do that like on a more routine basis.
Yeah, I think this is something that is also like an area for growth for myself is like as painful as it can be to do the med rec like on in a given visit. I think the med rec is actually a really, really valuable thing because it's a springboard for conversation about all of these topics. And so the doctors that I've seen that have done this really well do a lot of frequent med recs with patients and check in like, how's it going with this med? And you'll be amazed at like how often somebody's either not taking it or it's not working or they don't even know why they're taking a medicine. And it's, I think being just like more like adding that to part of your visit is important. So, I think it's especially a well visit, if if it's just like a general checkup, I would prioritize a good medication reconciliation. It just requires some patience, and it is tedious and it takes time, but I think it pays down the road. Like it's a worthwhile thing to do. And then use your pharmacist too. Like pharmacy's really good about that. Jordan writes, for patients who have an indication for a medication but aren't taking it and aren't particularly taking it, do you keep prescribing the medication? Yeah, that's a good question. I don't know. What do you all think? Like, I mean, I personally, if somebody's not going to take it, I don't usually bother. Like, I'm at the VA, so they'll actually like mail out the medicines. And certainly I've had times where meds have been mailed and then the veteran tells me, oh yeah, no, I'm not taking that, even though we talked about it. And, it's just kind of springboard for another discussion. But yeah, usually at that point, I'll just say like, okay, like, these are my recommendations. I think it's good to like explore why they might not be taking it. Because that can often be really helpful. Does anybody else have thoughts on that?
I think we're just about at time. Thanks for all the questions and thanks for leaving so much time for discussion, Cody. That was really great. Why don't we take about, I guess, like an 8-minute break and come back at 9:55 for our next talk?